Welcome to the funnel effect. We are diving deep today into a topic that's, well, fundamentally rewriting the textbooks on heart disease, spontaneous coronary artery dissection, universally known as STAD.
Yeah, this is a really critical deep dive.
Yeah.
SCAD just challenges that traditional view of a heart attack.
Yeah.
It's mainly affecting younger, often quite healthy women. And the research interest has just exploded like exponentially, really, just in the last decade.
Absolutely. And the detailed analysis we're getting into today, it's based on a really comprehensive narrative review. It's called Spontaneous Coronary Artery Dissection, a clinically oriented narrative review. And, we absolutely have to acknowledge the authors whose work we're distilling here. Quan Dang, Sonia Burgess, Peter J. Saltis, Sarah Fairley, Jacqueline Saw, and Sarah Zomman, a fantastic piece of work.
Right. Our mission today is pretty clear. We need to pull out the contemporary understanding of this condition because it's still, well, poorly understood in many ways. We want to explore everything, really, from how it happens, the mechanics, to the controversies in management, and importantly, the profound long-term impact on patients.
Okay, so let's start with the hook. The thing that really puts SCAD on the map, especially if you're working in, say, emergency medicine or cardiology. Now, while SCAD only accounts for a relatively small slice, maybe, 1% to 5% of all acute coronary syndromes overall, here's the kicker statistic. It's responsible for up to a staggering 1/3, maybe even 35% of all cases of acute myocardial infarction in women under the age of 50.
Wagner, it's just a complete demographic reversal, isn't it? I mean, when we talk about younger patients showing up with what looks like a heart attack, the default thought, the assumption is plaque rupture. But that's often wrong in this group. SAG needs to jump, like, immediately to the top of your suspicion list.
Yeah. Okay, so to really get why SAD is so different, we kind of need to throw out that image of the traditional heart attack, right? The one caused by atherosclerosis, that slow buildup of cholesterol plaque that eventually ruptures and clots. Let's unpack the core mechanism of SCAD then.
Right. SACAD is, at its heart, a mechanical failure.
Mm.
It's not really metabolic or inflammatory in the same way. The definition is the sudden formation of an intramural hematoma. So you have to picture the coronary artery wall. It's got layers,
Yeah.
right? The inside layer, the intima, the muscular middle bit, the media, and then the outer protective layer, the adventitia.
And this hematoma, this blood clot, it forms within those layers, not inside the main channel.
Exactly. Within the wall itself. It's a pool of blood, essentially, that forms between the layers.
Yeah.
Most often it's between the intima and the media, or sometimes just within the media. And this blood forces the layers apart. It dissects them.
Ah, okay. So it's not a blockage building up on the inner surface like plaque. It's more like a bruise inside the wall that's creating this expanding pocket.
That's a good way to think about it.
Hmm.
That expanding pocket, that's what we call the false lumen. It's this space filled with blood that has literally split the artery wall.
Yeah.
And the crucial distinction, it's worth saying again, is that SCAD is explicitly not caused by plaque rupture. It's not trauma. It's not something done during a medical procedure, iatrogenic causes. It's an intrinsic thing happening within the artery wall.
So how does this internal bruise, this false lumen, actually cause the heart attack, the acute MI?
It's all about mechanical compression. That hematoma, it expands really fast, and it's happening within the pretty fixed confines of the artery wall. So as it expands, it just pushes inwards. It mechanically squeezes the true lumen, the actual channel where blood is supposed to flow shut.
Ah, okay.
And this sudden, immediate blockage starves the heart muscle downstream of oxygen. That's what causes the acute myocardial infarction, or in some tragic cases, sudden cardiac death.
Like a pressure cooker just shutting down the flow.
It's amazing, though, how long this has actually been recognized, even if people weren't really aware of how common it might be. Yeah, it's not some brand new discovery. SCAD was first described really carefully in the medical literature way back in 1931. In the British Medical Journal, no less. The case was a 42-year-old woman already kind of fitting that modern profile, right? Who died suddenly. The autopsy found a dissection in her right coronary artery.
Wow, 1931.
Yeah. And the fact that the real surge in research and awareness has only really happened in the last 10 years or so,
Yeah.
it just highlights how easily this was probably misdiagnosed or simply missed altogether before we had things like high-resolution intracoronary imaging.
It makes you wonder, doesn't it? How many heart attacks in younger patients, especially women, might have been wrongly blamed on, I don't know, stress, or maybe just assumed to be standard coronary disease?
Oh, absolutely. The clinical suspicion just wasn't high enough. It wasn't top of mind.
Okay, let's pivot then to the WHO, because
Right.
this is where that picture of the typical heart attack patient just gets completely flipped on its head. CSCAD used to be thought of as incredibly rare. What changed? What let us see this prevalence shift?
Well, it was really a couple of things happening together. First, just increasing clinical awareness. The research community started talking about it more, publishing case series. But crucially, it was also technology, better access to and more routine use of advanced imaging inside the coronary arteries. Things like IVUS intravascular ultrasound and OCT, which is optical coherence tomography.
Right.
These tools let cardiologists actually look inside the vessel wall and definitively say, yep, that's a dissection, when maybe the standard angiogram just shows sort of vague, long narrowing.
And once we started looking properly, that huge gender imbalance became blindingly obvious.
All the stats are just undeniable, somewhere between 80% and maybe even 95% of all reported SCAD cases. They occur in women.
Yeah.
And just to hammer home that critical point for everyone listening, in women under 50 who present with an acute MI, SCAD is the culprit in up to 35% of those cases.
25%.
Yeah. And these are often not patients with the classic risk factors,
Mhm.
not severe high cholesterol or heavy smoking history. They're frequently otherwise healthy, active people.
And this is where the demographics get even more specific and, frankly, quite concerning. The link with pregnancy, what's called PSCAD. This targets women during or right after such a huge life event.
PSAD is a really significant subgroup. SAD is actually one of the most common causes of heart attacks associated with pregnancy. It's described in something like 43% of MI cases in pregnant women, and the highest risk window. Interestingly, it seems to be not so much during the pregnancy itself, but in that immediate postpartum period.
That sort of makes intuitive sense, maybe. Thinking about the huge hormonal shifts, the fluid dynamics involved around childbirth, is PSCAD generally more severe than SCAD that's not related to pregnancy?
The study strongly suggests, yes, it often presents a more severe clinical picture. These patients tend to have a higher incidence of ST elevation MI that's the most dangerous type of heart attack needing urgent treatment. And they also frequently show a reduced left ventricular ejection fraction, or LVEF.
Okay, let's just quickly clarify LVEF for our listener.
All right, so LVEF, it's just the percentage of blood that the left ventricle, the heart's main pumping chamber, pushes out with each beat. So a reduced LVEF means the heart pump function isn't as strong. PSCAD patients also seem more likely to have multi-vessel involvement, meaning the dissection isn't just in one artery, it affects several.
Wow.
Yeah, and being peripartum was actually found to be an independent predictor of major adverse cardiac events, both right at the time and then, years later as well.
Okay, so widen the lens a bit. Does this really striking female predominance hold true everywhere, across the globe?
Mostly, yes. It seems pretty consistent. But there are some, intriguing regional variations that make you wonder a bit about diagnostic practices or maybe even ethnic susceptibility.
Yeah.
There was one specific study mentioned focusing on the Persian Gulf area, where only about 50% of the SCAD patients reported were female.
50%. That's a huge difference from the, 80-95% we see in North American or European registries. Any ideas why that might be?
Researchers have a few hypotheses. It could be that different diagnostic criteria are being used there, maybe leading to some inclusion of more traditional atherosclerosis cases that kind of skew the numbers. Or it could reflect genuine ethnic differences in susceptibility. Another possibility, maybe less likely, but still there, is perhaps gender-related differences in accessing healthcare, or how quickly advanced imaging gets done, which might bias the patient pool towards men in that particular region. We don't really know for sure.
And we also see some interesting patterns in multi-ethnic countries like the US and Canada.
That's right. Caucasians seem to be significantly overrepresented in the big SCAD registries. They make up about 90% of the patients in those registries, compared to maybe 70% of the general population in those countries.
Why would that be?
Well, it could just be selection bias, right? Patients who tend to get referred to the big specialized tertiary centers that run these registries might happen to be predominantly Caucasian. Or it could point to a true biological difference in vulnerability. We're still trying to figure that out.
The source also mentioned the limited data in certain other groups, particularly Black or indigenous populations.
Yeah, and the hypothesis offered there is that these populations often develop traditional atherosclerosis earlier and perhaps more extensively. So if a patient develops significant plaque disease early on, it might either sort of obscure a SCAD event if it happens, or just lead to a misdiagnosis because the coronary artery disease picture dominates.
Right.
It definitely highlights the need for more focused research, that includes diverse ethnic groups.
Okay, so we've covered the who. Let's shift now to the how. Understanding the actual pathology seems crucial, especially since it directly impacts how you manage it. We've got these two competing theories about how the hematoma actually forms.
Right, the inside-out versus the outside-in theory. For a long time, the inside-out idea was kind of the main working hypothesis.
Okay, so describe that inside-out mechanism for us.
It basically suggests the first thing that happens is a mechanical tear, like a small break or fenestration, in that innermost layer, the intima. This little tear then allows the high-pressure blood from the main channel, the true lumen, to sort of jet into the arterial wall, pushing the layers apart and forming the hematoma. So it's like an internal breach that fills up the false lumen.
But the thinking has shifted now, hasn't it? Contemporary research seems to lean much more towards the outside-in theory. What changed our minds?
The outside-in theory flips the script. It shifts the focus from an initial tear to an initial rupture. It suggests the primary event is actually the rupture of the vasa vasorum.
Okay, let's pause there. What exactly are the vasa vasorum for the listener?
Good point. They're literally vessels of the vessel. They're these tiny, really delicate blood vessels that supply oxygen and nutrients directly to the artery wall itself, specifically to the media and adventitia layers.
So they feed the artery wall.
Exactly. And the outside-in theory says if one of these tiny vessels ruptures, the bleeding starts within the wall first.
Okay, so the hematoma forms from the outside layers inward, essentially.
Precisely. The bleeding creates the hematoma within the arterial wall first, and then this expanding hematoma compresses the true lumen from the outside, causing the heart attack. Sometimes the pressure might then cause a secondary tear in the intima, letting blood communicate between the lumens, but that tear is seen as a consequence, not the initial cause.
What's the evidence that's so compelling? Why did we shift away from the inside-out idea?
The big game changer was advanced imaging, particularly OCT, optical coherence tomography. When cardiologists used OCT to look really closely inside dissected arteries, they found that in quite a few SCAD cases, there was absolutely no communication, no visible tear between the true lumen and the false lumen.
Right.
Well, if the blood had come from the inside, the true lumen, you'd expect to see a tear, right? The fact that you can have this contained hematoma without an entry tear strongly supports the idea that the blood must have come from somewhere else, namely those ruptured vasorum within the wall.
That is a fundamental shift. And as you mentioned, that directly impacts how we think about treatment, especially drugs, because managing bleeding within the wall is a very different challenge than managing clotting on the wall surface.
Absolutely critical difference.
Okay.
Now let's bring the who back into the how. That strong link to young women, and particularly around pregnancy, suggests female hormones probably play a big role, doesn't it?
Seems likely.
Yeah, particularly estrogen. We know it affects blood vessels, things like vasodilation, new vessel growth, angiogenesis, maybe even the structural integrity of the artery wall. But we don't know the exact trigger mechanism. Hormonal fluctuations likely make the arterial wall, or perhaps those vasa vasorum, more susceptible at certain times.
And beyond hormones, there must be an underlying structural weakness involved. That brings us to fibromuscular dysplasia, or FMD.
FMD is absolutely central to the SCAD story. We need to be clear. FMD is not atherosclerosis. It's a non-atherosclerotic, non-inflammatory condition where the artery wall architecture is just disorganized. Particularly the medial layer, it's chaotic and inherently weaker.
And this weakness presumably makes those vasa vasorum more prone to rupturing, or the artery itself more likely to split under stress.
That's the thinking, yes.
Mm-hmm.
And the link isn't just theoretical. The co-prevalence is just staggering.
How high are we talking?
Really high. Comprehensive screening studies show FMD or other abnormalities in arteries outside the heart in up to 86% of SAG patients.
86%.
Yeah. It's why screening for FMD is now considered basically mandatory for anyone who's had a SCAD event. It's not optional anymore.
That underlying structural weakness must have some genetic basis too, surely. What does the genetics research show?
Well, we do see some rare cases where SCAD runs in families, sometimes even affecting identical twins, which strongly suggests a hereditary component. And while most SCAD isn't linked to those rare severe connective tissue disorders like, say, vascular Ehlers-Danlos syndrome, genome-wide association studies, GWA studies, have found common genetic variants that do significantly increase the risk.
The review highlighted one specific locus, PACTR1. What's the significance there?
Right, the PTTR1 allele on chromosome 6p24. What's really fascinating about this finding is that this same genetic variant is also strongly associated with FMD.
Ah, okay, so it links the two conditions genetically.
Exactly. It suggests this powerful combined risk pathway.
Yeah.
You have a genetic predisposition that contributes to the structural disorganization of FMD, and that FMD then makes the artery much more susceptible to the outside-in bleeding mechanism that triggers SASCA. And more recent analyses have actually found even more risk loci. I think up to 16 now, many of which seem to be active in vascular smooth muscle cells and fibroblasts, further reinforcing this idea that SCAD is fundamentally about the structural integrity of the artery wall.
Okay, so diagnosing SCAD is clearly high stakes, it happens acutely, and the management is so different from a standard heart attack. Invasive coronary angiography, ICA, is still the gold standard, but the big challenge is telling SAD apart from typical atherosclerotic plaque, right?
It's a huge challenge right there on the cath lab table.
Hmm.
You're looking at the angiogram, trying to spot specific visual clues. We know what atherosclerosis usually looks like. It's typically irregular, lumpy, often found proximally, in the bigger parts of the arteries. It's usually relatively short, maybe less than 10 millimeters, and you often see calcium.
Okay, so what's the visual signature of SCAD then? How does it look different?
SAD tends to have a much more distinct look. It often appears as a long, smooth, linear, or tubular narrowing. It's typically longer than plaque, often more than 10 millimeters, sometimes much longer. And critically, it tends to affect the mid to distal segments of the coronary vessels, further down the artery. Calcification is pretty uncommon. Also, a big clue can be looking at the other arteries in SCAD patients. The rest of the coronary tree often looks remarkably clean, free of significant plaque, which is unusual if someone has widespread atherosclerosis.
This really highlights why that angiographic classification system is so important. It gives clinicians a common language to describe these different appearances. Let's quickly run through those types, the SAW and Ahosani classification.
Yeah, this system is based purely on what you see on the angiogram, and recognizing these types really helps guide management, especially how urgently you might need more information. So type 1 is the classic, the pathognomonic appearance. You see this in about 29% of cases. You can clearly see the contrast dye staining both the true lumen and the false lumen. Sometimes it looks like a double barrel, or you might see a little intimal flap moving. If you see type 1, the diagnosis is pretty much confirmed right there.
Okay, clear cut.
Yeah.
But the majority fall into type 2.
That's right. Type 2 is the most common, making up over 60% of SCAD cases. What you see here is a diffuse, long, usually smooth narrowing or stenosis. Critically, the contrast dye is only visible in the compressed true lumen. You don't see staining in the false lumen because the hematoma is contained within the wall. And this type gets subdivided further into 2A and 2B. Type 2A means the stenosis is contained. It starts and ends between normal-looking segments. But type 2B is where the narrowing extends all the way to the tip of the vessel, or it ends in a complete distal blockage.
And that subdivision, 2A versus 2B, that's clinically really important, isn't it?
Oh, very important. A type 2B lesion, where it goes right to the end of the vessel, that implies a much more extensive injury. There's inherently a larger area of heart muscle at risk of ischemia compared to a more contained type 2A lesion. So that distinction can influence how worried you are and potentially the urgency, even though conservative management is still the general preference.
Right. Which brings us to the trickiest types to diagnose.
Yeah, type 3. This is the great mimic. It looks like a short stenosis, usually less than 20 millimeters, and honestly, it can look exactly like a standard bit of atherosclerotic plaque. This accounts for about 10% of cases, and often, if you don't use additional intracoronary imaging, you could easily misdiagnose this as plaque and crucially mistreat it with stents it doesn't need.
Okay, and type 4.
Type 4 is simply where the artery is completely blocked, totally occluded. Just looking at the angiogram, you often can't tell if it's SCAD or a big clot from a plaque rupture. The diagnosis here is often made retrospectively. Maybe the patient has another angiogram months later, and surprise, the vessel has healed itself. Or sometimes if you manage to carefully open the vessel with a wire, you can then use intracoronary imaging like IVUS or OCT to confirm the dissection.
Okay, so given that type 3 and type 4 really need confirmation, this is clearly where those extra tools, IVUS and OCT, become absolutely essential, moving beyond just the shadows on the angiogram.
Exactly. Intracoronary imaging is often key for getting diagnostic certainty in those ambiguous cases. OCT, optical coherence tomography, is fantastic because its spatial resolution is incredible. It lets you see extremely fine details.
So it's good for spotting that tiny intimal tear if there is one.
Precisely. Or just confirming the presence of the intramural hematoma, mapping its extent, seeing the compression of the true lumen really clearly.
And what about IVUS, intravascular ultrasound? What's its specific edge in the acute SCAD situation?
IVUS provides good images too, and it penetrates deeper, which can be useful in larger arteries. But its really unique safety-critical advantage, especially during an acute SCAD event, is that it doesn't need contrast injection to get the image.
Ah, right. Contrast could be bad.
Potentially, yes. Injecting contrast under pressure into an already dissected artery carries a theoretical risk of forcing fluid into that hematoma, making it expand or causing the dissection to propagate further down the vessel. You could actually make the patient worse. IVUS gives you detailed structural information without that risk.
But both of these tools, IVUS and OCT, they have physical limitations, right? Especially in the kinds of vessels SCAD often affects.
They do. Both catheters are still around a millimeter in diameter. That might sound small, but it can be too bulky to safely navigate into the very small, often quite twisty, tortuous distal vessels where SCAD frequently occurs. So, clinicians always have to weigh the benefit getting that diagnostic certainty against the risk of potentially causing more damage just by putting the catheter into an already fragile dissected artery.
Okay, one more imaging modality, non-invasive. What about CT coronary angiography, CTCA? Does it have a role?
CTCA is great because it's non-invasive, obviously, and it's very good at showing the absence of significant calcium or widespread plaque, which can help rule out traditional atherosclerosis as the cause. However, its spatial resolution, while improving, is still generally lower than what you get with OCT or IVUS inside the vessel. This limits its role as a primary diagnostic tool right at the time of the acute event, especially for those smaller distal vessels.
So its main value might be more for long-term follow-up.
That's its emerging role. CTCA is proving valuable for non-invasively checking if the dissection has healed over time, particularly in the larger vessels. But even there, we don't have perfect consensus yet. The reported sensitivity and specificity for spotting lesions that haven't healed are still only moderate, maybe around 72% sensitive, 54% specific in one study. So it's a useful tool for follow-up, but maybe not yet a perfect guarantee of healing. Okay, let's talk management. This is where SCAD really diverges from the standard playbook. You said the core principle is the conservative imperative. Why is that?
It's based on the natural history of the condition. The remarkable thing about SCAD is that in the majority of cases, it heals spontaneously.
How reliable is that healing, though?
It seems pretty reliable. Multiple studies using follow-up angiograms show that most SCAD lesions heal over time. The median time frame reported is often somewhere between 5 and 39 months, quite a range. But one study using follow-up CTCA actually showed a healing rate over 71% within just 80 days of the initial event. So because there's this high likelihood of the artery fixing itself, the default approach, whenever clinically safe, is non-invasive conservative management.
That Canadian SCAD registry you mentioned earlier found 86% were managed conservatively. That's a huge number.
It is, which leads to the question. If stenting, PCI, is the standard life-saving treatment for heart attacks caused by plaque rupture, why do we try so hard to avoid it in SCAD?
Because doing PCI in a freshly dissected artery is fraught with risk. The artery wall is inherently fragile, the layers are split, there's this pressurized hematoma sitting there. Any manipulation trying to pass a guide wire, inflating a balloon, deploying a stent, carries a significant risk of causing an iatrogenic dissection, basically extending the existing tear or creating a new one.
You could make things much worse.
Exactly. You risk propagating the dissection further down. There's also a real danger of inadvertently passing the guide wire into the false lumen instead of the true lumen, which is obviously disastrous. And even if you get the wire in the right place, trying to choose the right size stent when the artery wall is being compressed by this soft, dynamic hematoma, it's incredibly difficult. You might oversize or undersize it.
And that leads to problems later.
Big problems later. Things like late stent malapposition, where the stent doesn't stay pressed against the healed wall, restenosis, re-narrowing inside the stent, and even stent thrombosis, clotting within the stent. So intervention, whether it's PCI or bypass surgery, CBG, is really reserved for those critical situations. The patient has ongoing chest pain or signs of ischemia, they're hemodynamically unstable, like low blood pressure or shock, or they have really high-risk anatomy involved, like a dissection of the left main coronary artery.
Okay, so this heavy reliance on letting the body heal itself puts enormous pressure on getting the medications right. But you mentioned this is where we have the biggest evidence gap, a real lack of randomized controlled trials, RCTs.
That gap dictates almost everything we do pharmacologically. We simply cannot just blindly apply the standard drug protocols we use for atherosclerotic heart attacks. It might be ineffective or even harmful. And that tightrope walk is maybe most obvious when we talk about antiplatelet drugs.
Why are antiplatelets so controversial? I mean, they're absolutely critical for stopping clots forming in standard MIs.
Right, but think about the difference. In a standard MI from plaque rupture, you're trying to prevent a clot forming on the surface of that ruptured plaque inside the main lumen. In SCAD, the primary problem is blood that has clotted within the artery wall, that intramural hematoma. So there's this very real theoretical concern that giving potent antiplatelet drugs might actually promote more bleeding into that hematoma, causing it to expand and worsen the compression.
Ah, okay. But isn't there also a risk of clotting at the site of the dissection?
There is. The initial injury does expose tissue factor and other things that can make the local environment prothrombotic, meaning prone to clotting. So withholding antiplatelets entirely also carries a risk. It's a real dilemma.
A conflict between stopping the hematoma expanding versus stopping a new clot forming locally. What does the current data, even if it's just observational, tell us about using dual antiplatelet therapy, DAPT?
Well, the observational data is frankly conflicting,
Hmm.
which just highlights the uncertainty. There was one quite prominent European study that actually suggested patients on DAPT had a significantly higher rate of major adverse cardiac events, MACE, compared to those just on single antiplatelet therapy, like aspirin alone. They put a number on it, a hazard ratio, HR, of 2.62.
Okay, unpack that HR of 2.62 for us. What does that mean in simple terms?
It basically means that in that specific group of patients they studied, the risk of having a serious negative outcome, like another SCAD event, another heart attack, needing urgent revascularization, or even death, was more than 2.5 times higher for the patients who were taking 2 antiplatelet drugs compared to those taking just 1.
Wow, that's counterintuitive.
It is. And other smaller studies haven't always shown the same thing. Some have been contradictory, which is why the current sort of consensus practice, although it's not based on strong RCT evidence, is often a compromise. Maybe use DAPT for a limited period, say 3 months, during the acute healing phase, and then switch to lifelong single antiplatelet therapy, SAPT, usually aspirin. But we have to be honest, the definitive proof that this is the best strategy, it's still missing.
Okay. What about anticoagulants like heparin or warfarin?
Those are usually stopped pretty much immediately once SCAD is diagnosed, unless the patient has another very strong reason to be on them, like an artificial heart valve or atrial fibrillation. It's an explicit move to minimize any risk of the patient bleeding further into that hematoma, which is the core pathology we're trying to let heal.
So is there any medication that is universally recommended and actually has some decent data behind it in SCAD?
Yes, thankfully, beta blockers. They are recommended for pretty much all SCAD patients, provided they can tolerate them. Systematic reviews looking at the observational data have shown a pretty consistent association between beta blocker use and a significantly reduced risk of SCAD recurrence. The pooled relative risk, RR, was around 0.51.
So about half the risk of recurrence if you're on a beta blocker.
That's what the observational data suggests, yeah. The thinking is that beta blockers lower your heart rate and blood pressure. This reduces the physical force, the sheer stress of blood hitting the inside of the coronary artery wall, especially at the site of the fragile healing dissection. It gives it a better chance to heal without re-tearing.
But you're treating a generally younger, more active population here. Are there issues with side effects or people stopping them?
Absolutely. That's the downside. Side effects, particularly fatigue, can be really quite debilitating for younger, otherwise healthy people. And that often impacts long-term adherence. People just stop taking them, even though we have this evidence suggesting they reduce recurrence risk. It's a real challenge.
And lastly, statins. Standard after most heart attacks, but what about SCAD?
No, not routinely recommended. Unlike in standard MI protocols, statins aren't usually started just because someone had SCAD. They target cholesterol and plaque, which isn't the primary problem here. They'd only typically be used if the patient also has high cholesterol, hypercholesterolemia, that needs treating anyway, or if there's a strong suspicion that maybe there is some underlying atherosclerosis contributing to the picture. There was even one observational study, though it wasn't replicated, that suggested statin use might be associated with increased recurrence, but the reasons for that are really unclear.
So with all this uncertainty, particularly around antiplatelets, the focus really has to be on getting better evidence, right?
Absolutely. And the big hope on the horizon right now is the BA-SCAD trial. That stands for beta blockers and antiplatelet agents in patients with SCAD. This is really the first major randomized controlled trial specifically designed to tackle these critical knowledge gaps head-on. It's comparing beta blockers versus placebo, and it's also looking at different durations and maybe intensities of antiplatelet therapy. The results from BA-SCAD, when they come, should be truly transformative for finally establishing some evidence-based guidelines.
Okay, so we've covered the acute event and the tricky management decisions, but surviving SCAT is just the beginning, isn't it? Recovery seems to be a much longer journey with some really significant structural and psychological dimensions. Let's go back to that mandatory screening for fibromuscular dysplasia, FMD.
Yes, given that incredibly high co-prevalence, up to 86%, screening all SCAD survivors for FMD is now considered standard of care. And it's critical because FMD doesn't just affect the coronary arteries. It commonly affects other arteries too. The renal arteries going to the kidneys, the carotid and vertebral arteries going to the brain, arteries in the legs.
And finding FMD there allows you to look for other problems.
Exactly. It allows clinicians to detect potentially high-risk vascular issues, like aneurysms, dangerous bulges in the renal or cerebral arteries. Finding those might lead to closer monitoring or even preventative treatment to stop a catastrophic rupture down the line. Plus, having FMD itself seems to be linked to a higher risk of SCAD happening again.
So how is the screening actually done, this sort of head-to-pelvis vascular check?
Well, there are a couple of ways. Sometimes, during the initial heart catheterization, ICA, for the SAC event itself, the cardiologist might do some extra pictures, like non-selective angiography of the renal and iliac arteries. But for a really full, comprehensive screening, we generally rely on cross-sectional imaging. That means either CT angiography or MRI angiography, scanning essentially from the head down to the pelvis to look at all the major artery beds.
Is one better than the other, CT or MRI?
They both have pros and cons. MRI might be slightly better for looking at the complex arteries in the brain and neck, picking up subtle webs or small aneurysms. But CT is often faster and more widely available. The choice often depends on local expertise and availability.
Okay, moving on from structural screening to symptoms. One thing that comes up again and again is chronic chest pain, even months or years after the SCAD event when the dissection itself has apparently healed.
Yes, so this is a huge quality of life issue. It affects well over half of SCAD survivors. It's incredibly frustrating for them. They survived a heart attack, they're told the artery looks healed on scans, but they still get chest pain.
So what's causing that pain if the main blockage, the dissection, is gone?
The leading theory, and there's growing evidence for it, points towards microvascular dysfunction.
Microvascular dysfunction. Okay, what does that mean?
It means that the really tiny blood vessels, the small arteries and capillaries that branch off the main coronary arteries and feed the heart muscle directly to the microvasculature, may have been damaged or aren't working properly. This damage might be a consequence of the initial SCAD event itself, maybe inflammation or pressure changes. A key study found that over 70% of SCAD survivors who had chronic chest pain, despite their main artery looking healed on the angiogram, showed evidence of this microvascular dysfunction when specifically tested for it.
And this dysfunction means blood flow isn't regulated properly, causing pain.
Right. It means the small vessels can't dilate properly when the heart needs more blood, like during exertion. This leads to ischemia, lack of oxygen at the heart muscle level, causing chest pain even though the main pipe looks wide open. And that's something standard angiography doesn't easily pick up.
That reality, the potential for microvascular issues and the inherent fragility, must make cardiac rehabilitation and advice about physical activity really challenging. We know strenuous activity is sometimes reported as a trigger for SCAD.
It creates a really unique and delicate situation. On the one hand, cardiac rehabilitation is strongly recommended. It's been shown to be safe in SAD patients when done properly, and it offers huge psychological and physical benefits, building confidence, improving fitness. But standard cardiac rehab programs are often designed for older patients with typical atherosclerosis, focusing on pushing exercise capacity. For FAD patients, the goal is different. They need to avoid activities that significantly increase that shear stress on the coronary arteries.
So what kind of activities are generally off limits or need caution?
The guidance is quite specific. Patients are usually advised against very high-intensity exercise, especially things involving sudden bursts of effort or straining. Isometric exercises like heavy weightlifting are generally discouraged. Anything involving the Valsalva maneuver, bearing down, holding your breath under strain, should be avoided.
So what is recommended?
The focus is usually on low to moderate intensity aerobic exercise, like walking, cycling, swimming at a steady pace. Low resistance weight training might be okay, but it really requires careful, individualized guidance, often from rehab specialists who understand SCAD, to find that safe balance and hopefully reduce the risk of recurrence. SCAD-specific rehab programs are starting to be developed, which is great, But maybe the most critical piece of long-term recovery, and honestly, the one that's perhaps been most overlooked until recently, is the mental health impact.
This seems incredibly important. You have these young, previously healthy individuals, sometimes new mothers, hit by a life-threatening event completely out of the blue. The psychological trauma must be immense.
It really is a genuine mental health crisis for many survivors. Psychological disorders are exceptionally common, especially in that first year after SCAD. Think about it. The uncertainty surrounding the condition itself, the lack of definitive treatment guidelines we just discussed, the constant fear of it happening again, maybe during exercise, or just everyday stress, plus the sheer shock of the event. It's a perfect storm for psychological distress.
What specific issues are most common? Are we talking anxiety, depression?
Yes, high rates of anxiety, depression, and also post-traumatic stress disorder, PTSD, are frequently reported in studies. Anxiety seems to be particularly prevalent, often cited as the most common mental health issue after SCAD. And remember, these women are often trying to recover while juggling careers, young children, maybe dealing with the physical and emotional demands of the postpartum period as well.
It really underscores the need for support.
Absolutely. It's why specific mental health screening is now strongly recommended as part of comprehensive SCAD care. And also why peer support groups, organizations like the SCAD Alliance or Beat SCAD, can be incredibly valuable. Connecting with others who've been through it can make a huge difference.
Okay, wrapping up, let's just briefly touch on the future. What's needed in terms of research and maybe technology?
Well, on a basic level, we still face a data collection problem. Believe it or not, there isn't a specific code for SCAD in the main International Disease Classification System, the ICD-11. That actually hinders our ability to track the condition properly on a global scale and do large, robust epidemiological studies.
Seems like a fundamental fix needed there.
It really does. On the technology side, things are always advancing. There's hope that newer imaging tech, like photon-counting CT, which offers potentially much higher spatial resolution, might eventually improve our ability to diagnose SCAD non-invasively, especially in those tricky smaller vessels.
And what about artificial intelligence? Could that play a role?
Definitely potential there. AI models are actively being developed right now to try and interpret coronary angiograms automatically. The idea is that AI might be able to pick up subtle patterns or features suggestive of SCAD that the human eye might miss, particularly for those ambiguous type 3 or type 4 lesions. It could potentially speed up diagnosis and improve accuracy in the future.
Okay, so let's try and synthesize this whole deep dive. SCAD is clearly, rapidly emerging as a major cause of heart attacks, particularly in younger women. It seems strongly linked to underlying structural weaknesses in the arteries, like FMD, perhaps triggered by hormonal factors or stress, especially around pregnancy.
Right, and our diagnostic tools have gotten much better, leading us to favor that outside-in mechanism bleeding starting within the vessel wall. But the management is really defined by that conservative imperative. Let the artery heal itself whenever possible. Beta blockers seem key, but intervention like stenting is generally avoided unless absolutely necessary because of the risks.
But crucially, even if the artery heals structurally, the story doesn't end there. The high rates of chronic chest pain, which we now think is often due to microvascular dysfunction, and the really significant burden of psychological distress anxiety, PTSD, mean that recovering from SCAD is a long-term, multi-system challenge. It needs much more than just fixing the initial blockage.
Absolutely. It requires holistic long-term support.
So here's maybe a final provocative thought for you, the listener, to mull over. If SCAD is so strongly linked to FMD, and FMD represents a systemic issue causing structural vulnerabilities in arteries throughout the body, maybe we should start thinking about SCAD not just as an isolated acute heart event, but perhaps as the most sudden and dramatic presentation of an underlying pre-existing systemic vascular condition.
That's a really interesting perspective, a truly multidimensional challenge for medicine moving forward.
Thank you for watching The Funnel Effect.